If you're a psychiatric mental health nurse, you know this feeling. You're standing at a constant crossroads. On one path, you have a patient's fundamental right to choose for themselves, and on the other, you have your profound duty to keep them and everyone else safe. Trying to find the balance between these two, well, that's one of the toughest and most important skills in this entire field.
So let's just dive right into the deep end with the question that makes this whole challenge so real. Imagine this, a patient who you know absolutely needs treatment just says no. They refuse. What do you do? And this isn't some textbook hypothetical, right? This is a daily reality that puts your legal knowledge, your ethical backbone, and your clinical skills to the test all at the same time. To figure this out, we're going to build what I'm calling a nurse's compass. First, we need to find our true north, and that's the patient's unshakable rights. After that, we'll map out the legal guardrails that keep us on track. Then we'll calibrate our own ethical principles. And finally, we'll see how this whole compass actually works when we're navigating the messy realities of clinical practice.
Okay, first things first. Before a single diagnosis is made, before any intervention happens, we always start right here with the patient's rights. You have to think of these as the true north on your compass. Every single decision you make, every action you take, has to be oriented from this one fundamental point.
And wow, these rights are incredibly broad. I mean, it's not just about the big one, the right to refuse treatment, which is obviously critical. It's also about basic dignity, about privacy, and about getting information about their own care in a way they can actually understand. And these aren't just, nice suggestions. They are the absolute non-negotiable foundation for building any kind of trusting therapeutic relationship.
So, if patient rights are our true north, then the legal framework, that gives us our guardrails. And these aren't meant to tie our hands or restrict care. They're there to make sure care is delivered safely and legally, which ultimately protects both the patient and us as providers.
Now, a huge legal distinction you have to know is how a patient is admitted. Voluntary admission is pretty straightforward. The person recognizes they need help and agrees to treatment. But involuntary admission, that is a very high-stakes intervention. You have to meet some really strict legal criteria. The person has to be a danger to themselves or others, they can't meet their own basic needs, and, this is critical, their illness is so severe they can't even see that they need help.
And this really gets to the heart of informed consent. It is so much more than just getting a signature on a piece of paper. It's a conversation. It's a dialogue. The provider has a duty to explain everything: what the treatment is, the pros and the cons, the risks, what might happen if they do nothing at all, and what other options are out there. Only then can a patient make a choice that is truly informed.
People throw these two words around like they're the same thing, but they are worlds apart. As a nurse, you are constantly assessing a patient's capacity. That's a clinical judgment about their ability to understand and make a decision in this specific moment. Competency, on the other hand, is a legal ruling. It can only be made by a judge, and it's a blanket determination that a person is unable to make their own decisions. Think of it this way. One's a clinical call, the other is a legal verdict.
And finally, here are a few other key legal terms you absolutely have to have in your vocabulary. Take the duty to warn. This is a big one. It actually overrides patient confidentiality if a patient makes a specific, credible threat to hurt someone else. It's also vital to know the difference between negligence, which is failing to give basic care, and malpractice, which is a professional failing to meet established standards. And remember, assault can be just the threat of harm, and false imprisonment is locking someone up without the legal justification to do so. Understanding these is it's crucial for keeping everyone safe.
All right, so we've got the patient's rights, we've got the legal guardrails. Now we get to the real heart of nursing practice, our ethical compass. This is what guides us to provide care that isn't just correct, but care that is good and humane, often pushing us to do more than what the law strictly requires.
And this table just breaks down the nursing code of ethics into something so practical. I mean, look at Provision 1. It's not just about, be nice. In practice, it means using person-first language. Or Provision 2. Even if a client refuses meds, our commitment is still to them, so we give them information and respect their choice. And Provision 3 is a direct command: protect their privacy, period. Now, at the very core of bioethics, you have these two key ideas. Non-maleficence is the baseline, right? It's the Hippocratic Oath. First, do no harm. It's passive. But beneficence, that's active. That is the duty to step in, to prevent harm, and to actively do things that will benefit your patient. It's really the difference between not pushing someone into a river and actively jumping in to pull them out. And to round out that ethical compass, we've got these last three big ones. Fidelity, that's about being loyal, being fair, keeping your word. Veracity is simply about being truthful. And justice demands that we provide fair care and resources to everybody, no matter who they are. When you put them all together, these are the principles that build trust, and trust is just essential for healing.
Okay, we have built our compass. We've got our true north with patient rights, we've got our legal guardrails, and we have our ethical principles. This is where we bring it all together. So now let's put it to work. Let's see how this thing actually guides us through the messy, unpredictable world of day-to-day clinical practice.
Okay, take anxiety. Recognizing how it escalates is a perfect example of applying clinical judgment. When anxiety is mild, a person can actually be more focused, but as it climbs to moderate, their concentration starts to slip. By the time it's severe, their ability to think clearly plummets, and they get that horrible feeling of dread. And in a full-blown panic attack, they're just overwhelmed with terror and can be a risk to themselves. When you step in early, that is beneficence in action. You're preventing harm before it gets out of control.
This slide clears up a really common point of confusion. The key difference between bipolar 1 and 2 isn't how bad the depression is, it's how high the up phase goes. So bipolar 1 means there's been at least one full manic episode, which is often what leads to hospitalization because of things like psychosis or really poor judgment. But with bipolar 2, it's what we call hypomania. It's less intense, and hospitalization is more often needed because of the severe depression and suicide risk on the other side of that cycle.
And, when you're working with mood disorders, this is priority number one, no question. A suicide risk assessment is not a checklist. It is a vital therapeutic conversation. You have to ask directly about their thoughts, their plans, and their intent. In these moments, your duty to protect the patient's safety, both legally and ethically, it just overrides everything else.
A really crucial outcome of that assessment is a safety plan. And this is not something you just hand to a patient. It's something you build with them. It's a collaborative, trauma-informed tool that actually empowers them. You work together to identify their triggers, to practice coping skills, and to get their support system lined up. I mean, this is the perfect fusion of everything we've talked about. You're respecting their autonomy while also actively, ensuring their safety.
So at the end of the day, what does this all mean? It means this compass we've built, with its framework of rights and laws and ethics, it's not some rigid roadmap where there's only one right path. It's a dynamic tool. It's a compass that helps you stay oriented so that you can provide compassionate, holistic, trauma-informed care that truly honors the humanity of every single unique person you work with.
So I'll just leave you with this to think about. As our understanding of mental health keeps evolving and our healthcare systems keep changing, how can we continue to use this compass, this blend of legal duty, ethical commitment, and clinical skill? How can we use it to navigate our way toward a future of truly compassionate and effective care? It's a big question, and I'm glad we could explore the foundations together.